In the second part of Module 1, we're going to be discussing cardiac assessment. So in Lecture 1, we're going to discuss the primary survey and history taking. Our objectives: list and describe the steps of the primary survey for a responsive patient experiencing a cardiac emergency. 2. Listen and describe the steps of the primary survey for an unresponsive patient experiencing a cardiac emergency. And 3. Explain the components of history taking for a patient experiencing a cardiac emergency. 4. Determine common chief complaints in the patient experiencing ACS. 5. Use the OPQRST mnemonic to ask specific questions pertinent to a patient experiencing a cardiac emergency. And 6. Defend the importance of the paramedic having a basic understanding of home cardiac medications to aid in the history-taking process of a patient experiencing a cardiac emergency. So moving on to the primary survey. The primary survey is the first step after you've performed your scene size up and you've surveyed your surroundings, and you want to make sure in this situation that you are determining any type of life threats or anything that is of now importance. It's things that we must address: airway, breathing, circulation, disability, and exposure as well. So for the patient that is responsive, we will follow the normal steps: the airway, breathing, circulation, disability or their neurostatus, and exposure. The order of the steps for performing a primary survey differs depending on the type of cardiac patient. If the patient is unresponsive and is suspected of being in a cardiac arrest, then the order changes to C, A, B, D, E. First, assess circulation. We need to see if they've got a pulse, because we may need to go ahead and start CPR, which is very important in the chain of survival. Then we'll move to airway, breathing, disability, and exposure. But ultimately, with a primary survey, we've got to identify any of the life threats or anything that will cause issues for the patient before we can move on through our assessment. So the next important component of our assessment of our cardiac patient is going to be history taking. So acute coronary syndrome, although we're not going to go through the pathophysiology in this lecture, is a very big component of the cardiology class, and understanding ACS and the assessment findings is very important. So the definition of acute coronary syndromes are a series of cardiac conditions that are caused by an abrupt reduction in blood flow through a coronary artery. There's three major types of ACSs: unstable angina, non-ST segment elevation myocardial infarction or non-STEMI, or a ST segment elevation myocardial infarction, also known as a STEMI. So chest pain is often the presenting symptom of ACS and is going to be one of your more common chief complaints in the patient with cardiac emergencies. The patient may also complain of chest discomfort, maybe not necessarily pain, but it is discomfort, dyspnea, fainting, palpitations, and fatigue. Chest pain or discomfort is often the main presenting symptom in a patient with ACS, but there are atypical signs and symptoms as well in patients such as diabetic patients or patients that have nervous issues like neuropathy, or even women sometimes may experience atypical signs and symptoms. So chest pain is not always going to be the number one factor that they call 911. The description of discomfort is for assessing its significance. You want to get that description from the patient and have that patient give it to you in their own words, because you want to kind of get an idea of how they're feeling at the moment, and so you don't want to lead them into answers. And then an important part of the history taking is the OPQRST mnemonic, an excellent tool for chest pain: onset, provocation, palliation, quality, region or radiation, severity, and timing. Questions that you may want to ask using the OPQRST mnemonic for a cardiac patient may be: what is the onset or origin of the discomfort? What provoked the discomfort? What is the quality of the discomfort? The quality we typically rate on a scale of 0 to 10 if the patient is able to understand that question. Does the discomfort radiate? What is the severity of the discomfort? What was the timing of the event? If the patient has more than one chief complaint, ask the patient which symptoms started first and what would be the main symptom that's bothering you the most at this moment. Dyspnea, difficulty or labored breathing, is another chief complaint in ACS, and it may vary in intensity. It's very difficult to assess because it is a sign and not a symptom. Ask the patient to rate, like I said, the severity on a scale of 0 to 10. Now, dyspnea may also suggest other pathologies as well, such as pulmonary embolism, pneumothorax, acute pulmonary edema, pneumonia, or airway obstruction. Dyspnea that occurs on exertion or at rest suggests chronic obstructive pulmonary disease or left ventricular failure. Left ventricular failure causes fluid to build up in the lungs because of the back pressure of blood that's not being pumped out by the left side. Another term here, paroxysmal nocturnal dyspnea. The patient may report that they had a sudden onset of difficulty breathing in which they suddenly awakened when they were in sleep. This is often associated with left ventricular failure, and the patient starts building fluid up in their lungs. This usually begins 2 to 4 hours after the onset of sleep, and it may be accompanied by coughing, wheezing, and sweating. The patient may also experience a feeling of suffocation. Usually improves when you sit them up and let gravity to start work. And if your patient's also reporting a cough, find out whether it is dry or productive, because all of these signs and symptoms of left ventricular failure could actually lead you to a further diagnosis of ACS. Another common problem with cardiac patients is syncope. Most of the time, syncopal episodes are because of cardiac issues. For whatever reason, blood's not made it to the neurosystem or the brain, and they become ischemic and they pass out. Palpitations. Your patient may report palpitations, which is a sensation of abnormally fast or an irregular heartbeat. Sometimes they may say that it just feels like a weird beat that happens every now and then. Other times a patient may say that they're experiencing something they report as like their heart is beating out of their chest or their heart is running away. There's several causes of this. One of the main causes for a patient who has an otherwise healthy heart would be caffeine or stimulants, stress, or illicit drug use such as cocaine or amphetamines. If the patient is experiencing palpitations, you want to ask about the onset, frequency, and duration, and if they've ever experienced episodes of palpitations before. Did they have chest discomfort, dizziness, syncope, or dyspnea? And have they been experiencing fatigue? The patient may also report feelings of impending doom. If a patient's having a tried and true cardiac emergency and they report feelings of impending doom, you should take that as a very serious sign. Nausea, vomiting, they may have had trauma involvement, some type of blunt trauma to the chest, or even an issue that had caused hypoxia. After you explore the patient's chief complaint, inquire about pertinent aspects of the patient's other medical history. One important aspect of the medical history is medications. Medications can often tell you a lot that the patient can't tell you. Questions you want to ask about medications. Is the patient taking them as instructed? Have they had them filled? When did he or she last take their medications? Is he or she taking medications prescribed for someone else? That is a very common practice. Common cardiac medications include classes such as antiarrhythmics, anticoagulants, ACE inhibitors or angiotensin converting enzyme inhibitors, beta blockers, lipid lowering agents, diuretics, and also patients may have vasodilators such as nitroglycerin prescribed to them. Also ask about non-cardiac medications. You do want to find out if you're treating a patient for ACS, if they are currently on something like a phosphodiesterase inhibitor, commonly known as Viagra, Cialis, or Levitra, but they're Generic names for Viagra is sildenafil, for Cialis is tadalafil, and for Levitra is vardenafil. And not all patients that are on these medications are on them simply for ED. These are strong vasodilators, and they are often prescribed for blood pressure control as well. They may also be on some types of herbal supplements, or they may also be taking cardiac medications. Also inquire about any past cardiac history. Examples of this are coronary artery disease, atherosclerotic heart disease, valvular disease, aneurysms, pulmonary disease, diabetes. Diabetes is very hard on the cardiovascular system. Renal disease, vascular disease, inflammatory cardiac disease, any types of previous cardiac surgeries, and do they have any congenital anomalies as well that follow them into adulthood. So this concludes Module 1, Section 2, Lecture 1.